chimeric antigen receptor T cells, or CAR T cells, are autologous T cells, T lymphocytes that are derived from the patient. These have to be collected through a standard leukapheresis procedure at an authorized treatment center. And then the cell product in a self-contained and isolated sterile container are shipped to a manufacturing center. Right now, currently in 2020, there are 2 FDA-approved therapies, Axicell and Tisagen Lexacel. You'll have to edit that, and Tisacel. The 2 FDA-approved therapies are both directed against anti-CD19 on the target of B cells. And the chimeric antigen receptor is introduced into the patient's own T cells through a viral transduction method, which is done, again, in an authorized treatment center in a manufacturing facility that works with an authorized treatment center. And that viral transduction process takes a couple of weeks to take place, and then for those cells to expand to sufficient numbers that can then be used to be delivered to the patient for therapeutic benefit.
The CAR T cells, I mean, we have definitely in our center have been involved in quite a bit in CAR T cells with the NCI 7, 8, 9 years ago now. And then when the patients who are candidate for this with the approved CAR T cells is a patient who are in 3rd-line setting. There's a number of ongoing trials that are trying to look at if we can take advantage of this approach early on in a disease. But what's really important to think that, to summarize, that there's 3 different products among the most advanced in large cell lymphoma. So Axicell for the ZUMA-1 data, now that we have very long follow-up with this. The Tisacel, Juliet, and Lisocell for the JCAR trial. They're slightly different construct in terms of the signal introduction, CD28 for Axicell and 4-1BB for Tisacel and Lisocell. There's slight difference in the population, relapse refractory, the dosing process, the bridging therapy allowed or not. What is interesting is that when you look at the response rate from 52 to 83% and the CR rate from 40 to 58%. So in a population that really has no option, this is quite considerable. And what is interesting in that setting is that there's some late delayed response, up to 20–30% of patients can have a late response. Sometimes it can take up to a year. And that's really important. Typically, patients respond very rapidly, but it can take a while because it's a live therapy, and this is very important. It is, with a long-term follow-up now, what is interesting also is that we can see that particularly in the ZUMA-1, where we have the longest follow-up, we at 27 months having close to 40% of the patient doing really well and half of the patient alive. I mean, I think this is really, really well, very impressive, and potentially a good fraction of this patient can be cured. The issues that I would say is that the durability of the remission in this population, because the relapse is still definitely an issue, and the salvage after CAR T is very difficult. The patient who have CNS involvement, for example, is also a significant issue. There is some data, not a lot of data, particularly on Tisacel, looking at patients who had known CNS disease, including parenchymal disease with some durable responses, but overall there's not a lot of experience, and that could be a challenge, particularly with the toxicity from T cells accumulation in the brain. And toxicity from the CRS and the neurotoxicity that is very well known now. But we can manage this toxicity much better preemptively with tocilizumab and then with steroids. One of the questions that comes is that what's the best timing and the best combination that you can build on CAR T cell, and how we overcome the resistance to CAR T. Those are the issues that I can see in CAR T.
So the question is, discuss the need for hospitalization during and after treatment to monitor for CRS and neurotoxic events in patients receiving CAR T cell therapy. How does this affect patient outcomes and costs? So we currently have two CAR T-cell products approved for relapsed refractory diffuse large B-cell lymphoma, T-cell and axicartagene ciloleucel. Well, there has not been comparison head-to-head. In clinical practice, there are some differences in terms of toxicities and efficacies. Both have the inherent risk of CRS and neurologic events. There are differences in the percentage, probably more toxicities with axi-cel, the T-cell ciloleucel, but in general, those both carries the same risk. So patients had to be monitored closely in CAR T-cell therapy centers. One of the challenges is that some patients live far away from the center, so they have to relocate into the cancer center, and that adds cost. They need a caregiver that has to stay off work for a month or 2 months. That's another type of cost that families endure during the CAR T-cell therapy. And I'm not talking about the cost of the treatment, actually. CAR T-cell therapy is very expensive treatment. And also the management of the side effects, such as, the use of tocilizumab, admission to the hospital, use of intensive care unit beds. So those factors increase the cost. So whether that can impact the outcomes, I believe it will. So and the reason is because of these reasons, cost and logistics, some patients may decide not to do CAR T-cell therapy, even though it's a curative option.